Testing, testing, testing. Test. Okay. Testing, testing. 1, 2, 3, testing. Testing, testing. 1, 2, 3, testing. Testing. Dr. Ferrer's mic. Testing, testing.
Good afternoon and welcome to our first briefing of 2023. I hope that everyone is having a good start to the new year. Today I'll give an overview of our current COVID-19 metrics in LA County, as well as talk about some of the variables we continue to watch. In the upcoming weeks, we'll be depending on the residents of LA County to help minimize the impact of COVID-19. And I'll spend a few minutes at the end describing the simple steps we can all take to reduce transmission, as well as noting available resources. I'll take the next slide. I like to start the briefing each week by looking at our trend lines for case counts, hospitalizations, and deaths in LA County. Together, these provide a lot of information and a decent overview of where we are with COVID, as well as allowing us to compare where we are now to prior points in the pandemic. This slide shows the trend line from April 1st of 2022 through today. The green trend line shows the 7-day average of the number of cases reported daily and is measured using the vertical axis on the left. The average number of reported cases remains stable at between 2,300 and 2,400 cases per day through the end of December and beginning of January, but now it's decreased to about 1,900 cases per day, and you can see that on the slide. It's a relief to share that we're not seeing a large spike in cases right now. The trend line on case numbers provides some good insights about transmission levels, yet at the same time, we know that this metric doesn't catch all or even most cases, especially with so many people testing at home. The orange trend line shows the 7-day average hospital admissions. This past week, there was an average of 162 admissions per day. This is lower than the average of 192 admissions per day in late December. However, we did see an increase in the first week in January, where the 7-day average went up to about 211. Since then, though, we've seen a steady decline. It is important that we maintain perspective, though, as this number is still high. Our current average of 162 admissions per day is on par with the peak of the summer surge. This is a reminder that while our numbers are currently stable, they are stable at an elevated level, and we'd like to see all of these numbers continue to decline. The blue line on the slide shows the 7-day average number of deaths reported daily, and it's measured by the axis on the right. We're currently reporting an average of 23 deaths per day. This is up from an average of 15 deaths reported per day during the last week of December. Deaths are a lagging indicator, so the increase is not unexpected after the early December increases in cases and the high rates of hospitalization we've seen. However, it's always heartbreaking to see an increase in this number. I would like to offer my sincere condolences to the families and friends that have been impacted by COVID-19 and the death of a loved one. Next slide. This slide tells us that within the trend lines, there are some individuals at much higher risk for bad outcomes should they become infected. On this slide, we can see the impact of COVID hospitalizations and deaths across age groups. These graphs show the most recent 90-day hospitalization and death rates by age as of January 3rd. The graph in yellow shows hospitalization rates per 100,000 people. The first bar represents people 0 to 17 years old, and each bar shows a successively older age group, up to people 80 years of age and older. The graph in blue is divided into the same groups and shows the number of deaths per 100,000 people. One data point that stands out the most on both of these tables is how significantly people 80 and older are impacted by COVID-19. Hospitalization rates for the 80-plus group are nearly 3 times higher than for people 65 to 79, and death rates are nearly 5 times higher when compared to people 65 and 79. Further, you can see that compared to people 50 to 64, residents ages 65 to 79 have hospitalization rates that are more than 3 times higher, and the number of deaths per 100,000 people is more than 5 times higher. This emphasizes the extra risks that older age groups face, and it does underscore the importance of protections against COVID-19, especially if you're around people who are at risk of more severe illness, and you're at risk, therefore, of transmitting to someone older. Next slide. As we track the trends of COVID-19, we also acknowledge the vulnerability facing residents living in communities with high rates of poverty. Many of these residents are part of our essential workforce. On this chart, we see the age-adjusted COVID-19 hospitalization and death rates by area poverty for the 90-day period that ended on January 3rd. Like the previous slide, the yellow graph shows the hospitalization rate per 100,000 people, and the blue graph shows that death rate per 100,000 people. The first bar represents neighborhoods where less than 10% of households live below the federal poverty line. The second bar represents places with 10 to 20% area poverty. The next bar represents 20 to 30% area poverty, and the far right bar is places with greater than 30% area poverty. Across both graphs, we can see that the highest hospitalization and death rates for individuals are in the areas with the highest poverty rates. In fact, hospitalization and death rates are nearly double for people living in the poorest communities when compared to those living in the wealthiest neighborhoods. The rates on this chart are calculated from data over the past 90 days. What we know historically from prior surges is that as COVID transmission increases, these gaps widen, and we see greater inequities for the 1.3 million LA County residents who live in these areas with higher rates of poverty. This is another reason to collectively do everything we can to avoid a dramatic rise in COVID-19 transmission. With multiple factors, including unequal access to health-affirming resources contributing to these gaps, many individuals living in the communities with higher poverty rates are working at places where they're in contact with many other workers and at many places with many customers. During times of high transmission, this does translate to more exposures to COVID and other respiratory viruses. Next slide. Using the CDC's community levels framework, this week, LA County remains in the medium community level. Today's case rate is 127 new cases per 100,000 people, which is 27% lower than the case rate last Thursday. LA County has been in medium since December 22nd, after spending a couple of weeks the high community level designation in mid-December. For the first hospitalization metric, the number of new COVID-19 admissions per 100,000 people, LA County is currently at just about 12, which is well below the threshold of 20 that would move us back to the high community level. For the second hospital metric, the percentage of staffed inpatient beds occupied by COVID-19 patients, LA County is currently at slightly under 7%, and we've remained around 7 since December 8th. COVID-19 community levels help convey how much impact COVID is having on a community and the hospital system based on the most recent data. While hospital census continues to be very high across LA County, as healthcare providers offer care to those needing routine services and those impacted by the high rates of transmission of respiratory viruses, the impact of COVID on the healthcare system remains manageable and stable. Next slide. On this next slide, we have an overview of LA County's 8 early alert signals, and I'm happy to report that many have moved back to low concern after multiple weeks, with most of them being in high or medium concern categories. 2 metrics this week that do remain in high concern: the percent of specimens that are identified as a new subvariant or strain of interest, and we're currently tracking BQ.1 and BQ.1.1 combined, and the SARS-CoV-2 wastewater concentration. And I'll go into more details on the next slides about the early alert signals that are in this high concern category. I want to note that the 7-day average of the percent of emergency department encounters classified as coronavirus related is at 6%, placing it in medium concern, and the number of new outbreaks in skilled nursing facilities in the past 7 days is 18, placing it also in the medium concern category. I do want to take a minute just to talk about the outbreaks in the skilled nursing facilities. This alert was high concern throughout December, and at our December 1st briefing, I reported that there were 44 new outbreaks just in 1 week, and that's more than double the threshold to meet high concern. I do want to thank and credit the workers in skilled nursing facilities for quickly implementing safety measures wearing N95 masks, asking visitors to test, and working with public health to increase the bivalent vaccination rate. This work is appreciated, and I believe it's reflected in the lower number of new outbreaks that we're reporting today. The 7-day age-adjusted case rate for the lowest income areas, the number of new outbreaks in TK through grade 12 classrooms, the number of new outbreaks in settings with people experiencing homelessness, and the number of worksite cluster reports in the past 7 days, as you can see, are all green, meaning that they are of low concern. Next slide. We do continue to carefully observe changes in dominance for COVID-19 strains in LA County, especially as we see reports of XBB.1.5 increasing rapidly in other parts of the country, particularly the Northeast. Each week, a portion of positive COVID specimens are sequenced to determine the sublineage that caused the infection, and this can better help us understand transmission patterns. In LA County, as you can see, BQ.1 and BQ.1.1, that's light pink and purple bars at the top of the graph, continue to be the dominant strains, cumulatively accounting for 67% of sequenced specimens. The previously dominant strain, BA.5, that's shown by the red box, is now at 18%. At the top of the graph, we're tracking XBB, shown by the yellow bar, and XBB 1.5, represented by the orange bar. Since early December, XBB has actually been slowly decreasing. It counts now for about 5% of sequenced specimens. It accounted for about 5% of sequenced specimens back in early December, and now you can see a small drop to 3% of specimens. But XBB.1.5 has been slowly increasing, and it's at about 4%. The CDC calculates predictions of the estimated proportion of each COVID strain circulating now, since there's a 2 to 3 week lag in our lab reports due to the time it takes to sequence the specimens. For Region 9, which includes California, the CDC predicts that XBB now accounts for 7% of specimens, and XBB.1.5 accounts for 7.6%, while BQ.1 and BQ.1.1 together account for just over 70%. However, XBB.1.5 continues to increase nationally, and it's estimated to account for nearly 30% of sequenced specimens across the United States, with the fastest growing proportion of XBB cases being in the northeastern United States, where the estimate has been as high as 70%. As a reminder, XBB is a recombinant of 2 BA.2 strains and has a mutation that's been linked to increased immune evasion, which warrants particular caution, since we know that this impact can often be felt most among people who are very vulnerable, and that in the past these mutations have resulted in increases in hospitalizations and deaths. I think the question on just about everyone's mind is, how concerned should we be about XBB.1.5? I suggest we should be cautious. It's a new strain, it spreads rapidly, and it can evade prior immunity. However, I don't think anyone has a clear picture yet of what the impact will be. Looking at cities where XBB.1.5 is estimated to be high, some places have elevated numbers for new COVID-19 hospital admissions, while others are comparable to places with much lower estimates of XBB.1.5. There's not yet a clear data or patterns, and it may be that XBB.1.5 doesn't fit into the patterns that we're used to seeing. What we do know is that XBB.1.5 is still an Omicron strain, as opposed to an entirely new variant. Remember last winter we went from Delta to Omicron. Now we're staying with new strains of Omicron. And we do know what works to dampen the impact, including indoor masking and staying up to date on recommended vaccines and boosters. Next slide. The graph on this slide displays wastewater viral concentrations of SARS-CoV-2. Although this metric reflects a delay due to the time needed to process the samples, it does capture the level of circulating virus among everyone infected, not just those who have test results reported to public health. It's always helpful when the wastewater data echoes what we're seeing with the case rates, as you can see here. In accordance with the decline in case rates, there continues to be a drop in the SARS-CoV-2 wastewater concentrations. The blue line is the weighted average for viral concentration across our 4 wastewater treatment plants, weighted by the population that's served by each plant. And the reporting on this table is from May 29th, 2022 through December 31st. For the most recent week we're reporting on, the viral concentration is just below 70% of the peak concentration that we saw in July during our summer surge, placing us in the high concern category. So while it's declining, the concentration levels, as you can see, are not low. Nevertheless, seeing this decline is positive because it's a very different pattern than what we experienced in the 2 previous winter surges, where once transmission started increasing in early December, it continued to trend upwards for almost 8 straight weeks. The fact that we're also not seeing the increases we anticipated after the winter holiday is likely helped by people's actions. Thank you to everyone who's been testing regularly before gatherings, masking indoors, including upon returning to work or school, and staying home when sick. Next slide. While many schools are just starting to return to classes this week, and we don't have data yet, I do want to take a moment to look at what we saw in the fall after the Thanksgiving break, and what we may expect as students and staff return from winter break. This graph shows the TK through grade 12 school and youth program COVID-19 clusters from the first week of October of 2022 through the end of December. And you can see the 3-week period between November 27th and December 17th, after returning from the Thanksgiving holiday weekend, where weekly cluster reports increased to nearly 4 times the clusters that were reported during the last full week of class. As schools return this week, we could see a repeat of this pattern, which does bring a fair amount of disruption to schools, learning plans, and families. Public Health asks that students and staff test this week as they're returning and wear a well-fitting, high-quality mask for 10 days after returning to the classroom and the schools. Taking consistent action early could help change the pattern that we saw last fall. Because testing remains vitally important to slowing spread, since November, we've distributed nearly 2.4 million over-the-counter or at-home tests to TK through grade 12 schools to support response testing for symptomatic individuals and close contacts and testing before returning to school after holiday breaks. These testing strategies are critical for limiting the transmission of COVID-19 and minimizing disruptions at our schools. Next slide. Together, I know we can commit to a safe and healthy 2023. Simple steps can ensure that as a county, we protect people who are more vulnerable for illness, reduce respiratory virus transmission, and take steps to minimize the impact of new COVID strains. Wearing a high-quality, well-fitting mask in public, indoor spaces is something we can all do, and we should be doing, to limit the transmission of respiratory illnesses. We all should make every effort to mask for 10 days after engaging in activities that put you at higher risk of exposure, including traveling, attending large gatherings, or being exposed to a confirmed case. This is because 10 days is the average incubation period of COVID-19, when it can spread before you have symptoms. Using at-home tests are a simple way to make sure you're not passing anything along unintentionally. So continue to test before gatherings, if you've been exposed, or if you have any symptoms. With a lot of respiratory illness remaining across the country, it may be easy to pass something off as just the sniffles or a mild cold. However, what feels mild for one person could turn into a severe COVID case for someone else if you unintentionally pass along the virus. If you're sick, please stay home, recover, and take good care of yourself. And of course, please make sure you're up to date on your vaccines and that you have the bivalent booster and this year's seasonal flu shot. If you haven't had a COVID vaccine since August or before, the updated bivalent booster is available and formulated to provide protection against Omicron strains. You can receive the flu shot and the bivalent booster at the same time, and they are available at hundreds of sites across the county, including local pharmacies, community clinics, and our public health sites. Next slide. It is common to wonder if the COVID vaccine continues to be effective against the strains we're seeing now, including the BQ and the XBB strains. For reference, the bivalent booster is formulated to provide protection against the original COVID strain, as well as BA.4 and BA.5, two Omicron sublineages. The dominant strains that have been in the media, including BQ.1, BQ.1.1, XBB, and XBB.1.5, are all descendants of Omicron. A recent New England Journal of Medicine study showed that the people who received the updated bivalent booster had a better ability to neutralize all Omicron subvariants than those who received either one or two monovalent boosters. The authors reported a 5-fold increase in neutralizing antibodies against XBB for the bivalent booster when compared to neutralizing antibodies produced from the monovalent booster. The CDC also recently looked at effectiveness of the bivalent booster for people 65 and older this past November, when BQ.1.1 was increasing. The hospitalization rate for unvaccinated individuals 65 and older compared to individuals 65 and older who were vaccinated with the bivalent booster was almost 14 times higher, and the hospitalization rate for people vaccinated but without the bivalent booster was almost 3 times higher. This indicates that even for people who had already received the primary series or a monovalent booster, that was the old booster we all got last year, early last year, the bivalent booster provides some substantial additional protection from hospitalization. With more evidence that the bivalent booster provides significant protection against COVID-19, even as new strains are emerging, a critical strategy for reducing strain on the healthcare system is for more people to update their protection with the bivalent booster. In LA County, 21% of eligible people 5 years and older have received the bivalent booster. While this is a positive increase from 1 month ago when it was about 17%, there is a lot of room for improvement, since this means that about 4 out of 5 people who are eligible for the bivalent booster, nearly 6 million people in LA County, have not yet taken advantage of this protection. And since only 38% of those 65 and older who are eligible have received the bivalent booster, given the sobering data shared earlier about the significantly elevated risk for hospitalization and death among older residents, we ask that everyone who has an older friend or family member, please check in with them, find out if they have any questions, and see if they need help getting vaccinated with the bivalent booster. As with all the new tools available to lessen the impact of COVID, we recognize and appreciate the need for residents to have the information needed to make a good decision about how to best protect themselves, those they love, and our community. We're fortunate that the evidence to date indicates the bivalent booster is safe and offers significant protection against severe hospitalization and death. These booster protections are particularly important for those at older age and with underlying health conditions. As a reminder, all residents can receive the vaccine at no cost, regardless of insurance or immigration status. People can visit ph.lacounty.gov/how-to-get-vaccinated to find out more information about the bivalent booster, information on free transportation to and from a vaccine site, and options for in-home vaccination. Next slide. If you do find yourself sick this winter, please know that there are available resources to help you manage your illness. What feels mild at first can become severe, and it's better to test early and speak with a healthcare professional if you have symptoms, rather than waiting too long. Prescription therapeutics are available for both COVID-19 and for flu, but it's very important that you talk to a provider as close to symptom onset as possible. To be effective, Paxlovid for COVID needs to be started within 5 days of symptom onset, and Tamiflu, which is used to treat influenza or flu, should be started within 2 days of your first symptoms. If you test positive for COVID and you don't have a provider or you can't get an appointment, options are available. We have test to treat sites. To find one of those sites, you can go to ph.lacounty.gov/COVID medicines. You can also access telehealth services 7 days a week from 8 a.m. to 8:30 p.m. by calling the Public Health Call Center at 1-833-540-0473. Providers are available to answer your questions about symptoms, give advice, and if needed, they can prescribe medication, which can then get overnight sent to your home. Those looking to sign up for insurance or find a provider can call 211 to be connected with resources. In closing, every day we strive to make choices that are best for us, our families, and the communities we live in. We take the information we know and we do our best to ensure positive outcomes. We don't know how the upcoming months will look in terms of COVID. We know the pandemic's not over. However, we have likely entered a new phase, in part because of the tools now available to blunt the impact of COVID, and in part because of the choices people in LA County are making. My hope is certainly that we continue to report lower numbers and that transmission is significantly lowered in the weeks ahead. This protects everyone, especially those who remain vulnerable to bad outcomes if they get infected. Winter is likely to bring additional challenges, yet I'm encouraged by the changes we have seen thus far when compared to last year at this time. And I'm grateful for the many people in LA County taking steps to minimize the impact. I'm now happy to answer any questions.
Hello, Dr. Ferrer. I would like to ask you about tracking COVID hospitalizations. Noting that we're, 3 years into this, do you think it's time to update how we track COVID hospitalizations, specifically referring to the fact that for a long time now, the majority of patients have been there with COVID? Shouldn't we just be looking at for COVID? Isn't that more a true reflection?
Yeah, it's such a good question, and obviously, we really like to adhere to sort of national guidance and state guidance because the hospital care system, is a vast system across the country. I do want to note a couple of things about being admitted with COVID illness and being admitted for something else, and then you have a positive COVID test. One reason why CDC hasn't changed their guidance is because many of the people who test positive for COVID on admission they were asymptomatic, and they go on to develop some COVID illness while they're in the hospital that does impact their care. Let me just drink some water. So I think that's one reason why there hasn't been that change. It's not a static moment in terms of the care that patients receive. At the moment that they get admitted is the status that you're looking at. But clearly many of us know that once you test positive for COVID, lots of people go on to develop some symptoms, and that could influence their need for care at the hospital. So I think it is complicated. I do think people are looking at what's the best way to capture the true burden of COVID positive patients on the healthcare system. That's particularly going to be important as we develop better tools to manage the care for people who are sick. Not just the therapeutics, but also people's knowledge about just sort of over time how to better care for COVID positive patients. But I will leave those decisions to both the federal folks at HHS and at CDC as well as our state folks. And then we would just adhere to those changes should they be made.
As far as I understand, so just so I'm clear, so you're doing this just based, you're following CDC guidelines only?
Yeah. I mean, we are actually a little bit stricter, but you know that we also capture incidental versus people who are there who enter in because they had COVID disease.
And one of the reasons why I'm bringing this up is because I've talked to emergency room doctors who say it's just when you're there for an incidental case, it's much less resource intensive, so it's not stressing the hospital, but that still counts as a COVID hospitalization. So when we hear these numbers, it can be misleading.
Yeah, I think we should separate what goes on in the emergency room where some people go in and out and what happens in a hospital stay where people are there for multiple days. Because as I said, people who test positive on the date of their admission could be asymptomatic that day, and then as we have all seen, a couple of days later they go on and they develop some illness, and that would impact their care, and you'd want to capture that as well.
Doctora Ferrer, ¿le puedo hacer una pregunta en español?
Sí, seguro que sí.
En Los Ángeles, ¿cuán eminente es el peligro de la variante XBB.1.5? Y cuando es más contagiosa, ¿debemos de tener más distancia de 6 pies o no necesariamente?
Yo creo, es una pregunta bien importante. Yo creo que lo que tenemos que hacer es lo mismo que estamos haciendo. Usar las mascarillas siempre cuando estamos adentro. Tenemos todos que asegurarnos que nuestra familia tienen sus vacunas y tienen el booster que tenemos ahora. Y cuando estamos enfermo o enferma, tenemos que quedarnos en la casa.
Pero no hay un mandato que diga ni nada que diga que más distancia.
No, la cosa es con la distancia. Al principio era la ruta de transmisión era por droplets. Ahora sabemos que sigue en el aire, entonces la distancia no es tan importante cuando estamos adentro. Si tú tienes COVID y estamos aquí en este cuarto y tú no tienes una mascarilla, tú sabes, cuando usted estás hablando, el virus se mete por el aire y todos nosotros, si no tenemos las mascarillas, estamos con riesgo de sacar la virus, de enfermarnos.
Hi, these questions are from Ron Lynn, who sends his best, and
Happy New Year.
he claims that these are 3 questions.
Okay.
So,
I'm putting my pen down.
so we saw 164 COVID deaths for the most recent week, a new peak for the autumn and winter, and higher than the summer peak of 122 weekly deaths. Why are deaths higher now than in the summer when it appeared hospital numbers were comparable and cases were higher? Is it that older people who haven't gotten boosted are more vulnerable now? That's one. Number 2, why do you think we haven't seen a second winter surge after the winter holidays? And do you think we're in the clear for the rest of the winter? And number 3, are you hearing of long COVID continuing to be a concern?
Yeah, thanks. So, I really respect the question, and I'm glad you're asking about deaths, because, deaths are high, and it's really upsetting, and it's why we show the data that indicates that people who are older have a much higher risk. We think part of it could be the vulnerability, as you said, of waning protection, either because it's been a while since they were infected, or more likely for many older people, it's been a while since they had an additional booster vaccine. I mean, the data I show is sobering, that amongst older people, we only have 38% who have taken advantage, 38% of people eligible who have taken advantage of getting boosted. And, we believe that we could prevent more deaths, certainly more hospitalizations as well amongst older people if we could increase the rate of uptake on the bivalent boosters. But I also appreciate the fact that people who are older are also more likely to have underlying health conditions that can contribute to that increase. And particularly in the winter, it would be good to do some reviews of everyone's records to better understand the comorbidity issue. Are people who are passing away from COVID and older also experiencing other respiratory viruses? Because we've had a terrible season, and was that contributing? Because we didn't really have a surge in other respiratory viruses in the summer. I think that's the only way we're going to get to the answer. We're actually going to have to go back and look and do some record reviews to better understand exactly what are the factors contributing to, as you noted, a slightly higher rate of death now than what we saw in the summer surge. It also could be that at the end of the day, the strains that are circulating now, while for the majority of people may be continuing to cause very mild illness, for older people and for people who have serious underlying health conditions, we could in fact find out that the strains that are circulating now are actually leading to more more severe illness for some groups of people. So again, as with changing strains and rapid evolution of the virus, we have a lot that we always have to continue to try to learn.
Well, as a follow-up to that, should we be looking concurrently at the prevalence of influenza and RSV, and do we really have a way to do that comprehensively?
Yeah, it's also a great question. That's why we're tracking wastewater now for influenza and RSV, both which have declined significantly, to try to, really get a handle on what exactly transmission looks like. Because you're right, neither one of those is reportable to the health department. So we're getting our data on, sort of what transmission looks like from our Sentinel labs, which gives us a decent picture, probably as good a picture as we're getting for case rates for COVID now. But the wastewater data is actually what we're using to better gauge what's happening. The second question, do we think there could be a second surge? Why wasn't there a second surge? I do want to note that in the past, having a lot of holiday activities has always led to increases in transmission. Now, we can claim that some of the problem is that our case numbers are very flawed, but I would point to the wastewater concentration data, which, while it's delayed by a couple of weeks, gives us an indication right now that there is still somewhat of a decline. While high levels of concentration, it has declined. We'll have to watch it for the next couple of weeks to better understand sort of what's going on in the beginning of January, because that data reflects what happened through December. But my sense is that we have more immunity that's really helping us particularly avoid hospitalizations for lots and lots of people. More immunity because people have been infected in the past, and more immunity because really at this point over 80% of the population is fully vaccinated, and lots of people have had at least one or more booster doses at this point. I think that contributes. I also want to thank everybody who's being more careful. I think that also helps. I see a lot more people wearing masks, certainly on airplanes. We saw about a third of the people. I was on a flight recently that's up from what I've seen in the past. So I do think, again, with lots of respiratory viruses circulating, I think more people are comfortable understanding that there are some protections that really make sense for us to continue to do. And the last question, do we continue to worry about long COVID? We worry a lot about long COVID, and we track all of the studies. It's very real for millions of people across this country who are debilitated by the symptoms that they continue to experience. We're pleased to see that there are more providers that are both being trained and offering services for people who are experiencing long COVID. That is symptoms that either start or don't go away at least 4 weeks after their initial illness. I think we have a lot to learn. I appreciate the VA has been doing some really good studies on this as well, because we could end up with, as many, somewhere between 5 and 10% of people who have been infected needing long-term care, and that will have implications for all of us. I think I got to all of them.
Buenas tardes, doctora. Candy Martínez para Visión Latina. Tuvimos la experiencia que con el COVID o Corona-19 pudimos lograr controlar un poco la situación a través de la vacunación, el distanciamiento y el uso de mascarillas. También, lógicamente, la gente siguió el protocolo al ser 100% obligatorio en los lugares públicos. ¿Se contempla nuevamente la idea de poder implementarlo nuevamente obligatorio el certificado de vacunación, así como mismo las mascarillas?
Por ahora no. La razón es que hay mucha gente que ya sacaron las vacunas y también allá hay mucha gente que se enfermaron. Por ahora no. Por ahora vamos a darle mucha información para que la gente saben lo que pueden hacer para protegerse, pero no tenemos ningún dato que sirve para decir que tenemos que irnos de nuevo a sort of those mandates. Okay, gracias.
Okay, now these are my questions. I'm
Okay.
Howard, the education reporter here. If you were a parent of school-age children, what health issue would be of most concern to you? What would you be most worried about at the moment? And I'm just making that a more general, not just a COVID-specific question. And what would you do about it? And what would you like your school or school district to do about it? Because I noticed that KIPP charter schools, for instance, is requiring masking.
Yeah.
LA Unified in most places are not.
It's a really good question. And I think in part, school communities, just like communities across the country, are different in what their experiences have been with COVID to date. I also think there are many parents and students who feel very vulnerable when transmission is high. And one way to make sure that it's really not just parents and students, it's also staff and faculty, feel comfortable working in an environment where people are going to be together for many, many hours, often indoors, particularly in the winter, is to go ahead and ask people to keep those masks on. So I applaud those school districts that are looking at their community and making those decisions. We strongly recommend at this point in time that people do continue to wear those masks indoors, but we have allowed for school districts and for businesses to go ahead, assess their own individual situation. You do see us saying how important it is as people are returning to keep masks on, just because of what we experienced after Thanksgiving, which is this pretty big uptake. And we had a lot of clusters at schools, and we had a lot of clusters at workplaces. So we know how much risk there is as everyone comes back from these vacations to having transmission. And the start of the question was, as a parent, what do I want to see at school? And I frankly, as a parent, I'm a grandparent now, but I was a parent of school-age children. I want to see that my children are in an environment that really values the health and well-being of everyone, and that takes appropriate steps to protect the health and well-being of everyone. And I want to say, I appreciate there are a lot of schools that are focusing on indoor air quality, some long-term issues that really benefit protecting people in those buildings from the spread of other illnesses and other conditions. We have a lot of children with asthma. So everything we can do to improve the environment at schools and create safety in that environment, I think all parents would get behind.
Okay, and thank you, by the way. In terms of COVID, RSV, and flu, and you can take these together or separately, whatever makes sense, you talked about the disparity with higher poverty and lower poverty communities. Could you attach some more geographic boundaries to that? Like, is it South LA, East LA, and also maybe the ethnic parameters, Black families, Latino families? That would be my next question.
Yeah, it's much harder. I can't do it for RSV or for influenza because we don't have granular data. So it's a little bit harder there. But we could use the wastewater data, and we could start using wastewater data to pinpoint communities that are higher risk. We certainly can show you on the case rates, the hospitalization rates, and the death rates, what those communities are. And as a matter of fact, I believe we still map that out. So I'll check, and I'll have our team. If we're not posting that map updated every week, we'll just go ahead and send it to you, Howard. So you can actually see which communities. But it is traditionally communities that we think of as having high rates of poverty, and those also tend to be communities that are predominantly occupied by residents who are Black and brown.
And I guess this is more of a science question here, but if we're looking at the wastewater, which is a pretty reliable measure since it's not an option that people choose to get tested or not, or to report the test. If we looked at today's wastewater levels, what would that tell us about the prevalence of the virus compared to when more people were testing? What would it say about where we compare to other parts of the other periods of the pandemic?
Yeah, we can send you that data as well. We've done that analysis before, where we actually plot on the same graph, sort of what our testing data shows us, since the beginning of the pandemic, and from the time we've been collecting wastewater, how closely those are aligned or how poorly they're aligned. So off the top of my head, I don't want to misspeak on the periods where they're not well aligned, but clearly since Delta, we've seen less alignment because there's just been less reporting. We've had a lot more people that are able to test at home.
So would we say that, I mean, roughly speaking, maybe the result, can we make a comparison like the results should be twice as much as they are, or three? Or is that really hard
I mean,
to do?
we're not making those kinds of projections, but there are other scientists that do, in fact, sort of extrapolate from that data. And, you know, there's some prevalence studies that are still done. So there are some people that are extrapolating from that data. You know, what do they think is the true burden of infections in a given, you know, area based on what they're seeing in terms of other markers of illness. But we're actually not doing that ourselves, but we can definitely show you on a graph what the correlations look like between our case data and our wastewater data.
For an accurate picture, can I get the current ratio of for and with hospitalizations? And then I'm going to rephrase my question about tracking the COVID hospitalizations, noting that Massachusetts went ahead and updated how it tracks, and it does separate. Why can't we? That's one question. And then because...
Well, let me just answer that,
Okay.
because as I said, that was a decision made by the state. And if our state made that decision, we would align with that decision. I think because the hospital systems are bigger than sometimes the county systems, and there's implications around that tracking, and there's also implications for how the hospitals collect the data, we would want it to be a statewide decision.
And the ratio?
I will double check. 2 weeks ago, it was 50-50, but that was still while we were, you know, sort of leveling off, not coming down. So we'll get that number to you.
Okay, two more. You have to feel good about the fact that it seems like talk of a potential mask mandate is behind us. And then also your thoughts on the Pentagon dropping its vaccine mandate for troops. I'm sure I can't imagine you agree with that.
Yeah, I mean, I can't really comment on the Pentagon's decisions and you know, what went into those decisions. You know, I appreciate that different businesses and entities, including government entities, are re-looking at the data and refreshing, if that's a good word to use, refreshing the policies based on the experiences over the last 3 years, which one of those experiences is that lots of people have been infected. So I think that goes into that decision. And the first question was?
The mask.
Oh, yeah. I mean, you know, we're of course, you know, we're just very relieved that our numbers are declining, and we appreciate all the efforts people are making to make sure that transmission stays low.
Dr. Freer, we had a question emailed into us from Kristen Huang at Cal Matters. She was hoping you could address the status of Optum-Serve testing and vaccination sites in LA County. She says CDPH indicated that any sites operating below 50% capacity in December would be demobilized, and she was wondering if LADPH has been notified that any of the sites in the county here would be closed, and if so, on what timeline?
Yeah, it's a great question. The community testing sites in LA County are actually coordinated through the Department of Health Services, so it would be better to talk to them. They would actually have the most accurate information. I do want to say that I know that the county is committed to making sure that as people need to get tested, there's ample places for them to go and get tested. And as I noted, in schools alone, we distributed 2.4 million test kits, and we've probably distributed an additional 2 million out to community providers and at higher risk settings.
This is another science question. What would make something a new variant versus a new strain of Omicron? Because as you explained of that, I realized that I didn't know what would make one or the other.
Yeah, I mean, I think the layperson's answer is that what we've been seeing for the last few months have been new strains of a very similar virus, which is an Omicron virus. They're all under COVID, they're all under the COVID-19 virus family. but the evolutions are very different. And again, the scientists actually take a look at what that virus looks like physically looks like, to determine how closely it resembles a variant or how different it is. And then when it's different enough, they decide that it's in fact a new variant. I think that's the simplest answer.
And you may have addressed this, but on schools specifically, given that many children are asymptomatic and that there's no required reporting of viruses, I mean, how reliable is our outbreak data or even our case count when it comes to schools?
So you're absolutely right that there's no longer a requirement for schools to report individual cases to us, but there is a requirement for them to report 3 or more cases that have happened over a 14-day period. Well, I do think some people are reporting it to them because they're absent and they report it as part of being absent. So I do think people are reporting it. But, you're right to note some people may not be, but I think many people are. And certainly when there's a cluster of cases, the school tries to make sure they're getting as accurate a count as possible. Those clusters are happening generally in a classroom setting, in a club setting, in a sports setting, where it's pretty easy to track that there's been transmission at the school in a particular setting.
So when you look at those numbers and when because you show the comparison in December,
Yeah.
I mean, are you looking at those mainly? What we're learning is that the general picture is much worse, or are we to take those exact numbers very seriously?
I would agree with you that what you're getting, similar to what you get with the case trend lines, is a sense of how big an increase or decrease we're seeing across the school communities. As opposed to literally, those are the only schools that have 3 or more cases over the last 14 days. I would completely agree with you on that.
Doctor, that 3.7 that you mentioned, just to clarify, does that mean 3.7 of the cases are that variant in LA or no?
It means of the sequence specimens. So it's a very good question.
So do we have cases or not?
Yes, we do have cases.
Okay.
Those are cases.
Okay.
Okay. Every lab test represents a case.
Okay.
A person who has COVID. What we don't have is the true number, because what we're doing is we're collecting a sample of specimens that have tested positive, running them to look at sort of their genetic makeup, and then being able to type them as to which type of strain we're seeing in the lab. So it's it's a sample. I'm not even going to go to representative sample.
So
But it does represent cases. It's honestly, those are all people who tested positive.
Okay, so there are cases, but it's not quantified.
We don't, 100% of the positive cases don't get sequenced.
Okay. Okay, thank you.
Okay, that's a very good question.
My last question is about XBB.
Yes.
I think you said that we still don't know how it's going to react to us or how we will react to it. But on the East Coast, haven't those cases peaked from XBB? So we do know that it is more like a typical Omicron variant?
Well, we know that it's an Omicron strain. And we know that the data looks very mixed in the places that have lots of that particular strain. And that's why we're still trying to figure out exactly what the impact is. There are some places, so I'll put out I don't have the exact data, but Boston, for example, their case rate has gone way up, along with the percent of their sequence samples that are positive for XBB. Does that truly represent an increased risk associated with XBB? Maybe, but then if you look at New York's hospital rate is actually more similar to ours, and we don't have a lot of XBB. So I think we have to watch this a little bit longer and really try to figure out what that impact is. Every time people get hospitalized, there's all kinds of confounding. In the past, we used to show you some slides that would show you what percentage of them had underlying health conditions, et cetera, so people could understand well, all the factors that go into why somebody might end up being hospitalized. One thing I'd also say is sort of access to therapeutics probably plays a role here as well. In places where it's pretty easy to get therapeutics and there are good systems set up, you might be avoiding some of those hospitalizations, even from a new strain. I think we're probably done. Oh, is there one more question? Oh, good. Okay. Just because I'm